All right. Well, thank you for coming. This is my final for Nurse 494. Name is Luke Bowler. Um, and let's get started. Okay. So the evidence-based practice problem here, as patients spend their time in hospitals, they're often subjected to developing pressure ulcers. These are sores that are generally caused by having prolonged pressure on skin. Other causes of pressure ulcers are increased friction, moisture, and tension on the skin. Patients who are most at risk for this can be those who are bedbound for long periods of time. Generally, these patients are older and have a loss of epidermis, making them more susceptible to bed sores. Along with aging, other issues can cause these sores, such as lack of proper nutrition, dehydration, inability to ambulate, and other medical problems such as cardiovascular disease, respiratory illnesses, peripheral artery disease, cancer, kidney disease, and diabetes. Although it is not solely the nurse's responsibility to help avoid these pressure ulcers from developing, they are the primary caregivers and spend the most time with the patients. For happy prevention, the method used is frequent repositioning for dependent patients. That's patients who are often intubated or just unable to turn themselves. Repositioning of the patient every 2 hours minimizes constant pressure on bony prominences such as the coccyx and heels. Evaluating this method directly correlates with the reduction of HAPIs and the possibility of them worsening. As a pressure injury worsens, it is classified into different stages. Stages 1 to 2 may be controlled with interventions. However, stages 3 and 4 and unstageable HAPIs are oftentimes harder to control and could potentially need surgical treatment if left uncared for. This problem, HAPIs in general in hospitals, it's a worldwide issue with a recent meta-analysis by Lee and colleagues showing that nearly 8.4% of hospitalized patients will develop HAPIs at some point during their stay. For prevention of HAPIs, the method used, again, is frequent repositioning. And then why is it important? Well, obviously, patient safety is the biggest thing, controlling their time spent in the unit. The Agency for Healthcare and Research and Quality estimates that it can cost an organization anywhere from $20,000 to $151,000 to care for individuals with a HAPI. This also burdens the patient, as Medicare estimates an additional $43,180 that is added onto a hospital stay. Shareholders will want to see a difference that proper management is making within the hospital, and by tracking a downtick in HAPIs, the cost of each patient's stay will also decrease. So for this, my PICO question, for trauma ICU patients 50 years and older that are vent dependent, will a turn team program dedicated to frequently turning patients compared to having no team help to decrease the amount of HAPIs within a 6-month period? Older adults run a higher risk for HAPIs. That's the 50 years and older. This coupled with patients' dependence on nursing staff for frequent turns and pressure relief can accentuate the possibility of HAPIs. A turn team will not only lessen the load for the primary nurse per patient, but can overall help to reduce and prevent HAPIs from occurring. Okay, so some negative impacts of HAPIs: burden for patients, burden for staff. Through a series of research and analysis, the subject of HAPI prevention was heavily reviewed and critiqued. Articles research primarily focused on how HAPIs can impact patients' lives in a negative way, and how they create a burden for staff and hospital. Preventions of HAPIs is a hospital-wide goal. This includes all members of care and sometimes family. Articles heavily focus on the importance of turns, as well as how to implement this into daily cares by creating a team to take on this role. Or the articles were heavily focused on that. As far as cost is concerned, again, just kind of touching back on that, an average cost could, for patients who develop HAPIs, depending on the severity, can range anywhere from $20,900 to $151,000. Let's see. So the importance of turns, every 2 hours, that's kind of questionable. I mean, everyone kind of thinks things differently, but that is considered to be the golden standard, is every 2 hours of repositioning helps immobile patients to minimize direct pressure on the skin, and it allows enhancement of blood perfusion in affected areas. Another great tool that was pretty prominent in the literature was the usage of the Braden scale. This is a tool that examines patients' potential for skin breakdown and is broken down into 6 subscales that include sensory perception, skin moisture, activity, mobility, nutrition, and friction. Depending on the score that the patient receives, is what they are, kind of their risk for developing a HAPI. It can range from very high, which would be a score of anywhere from 6 to 9. No risk at all would be a score of 19 to 23. And then kind of in between is more of moderate. As far as missed opportunities, this can be caused due to understaffed workforce, just routine care that we should really be doing anyways can also be missed because of this. Nurses are oftentimes understaffed and overworked during their shifts. Routine care, such as every 2-hour turns, could potentially be missed because of other responsibilities, such as med administration, admission and discharge processes, and required documentation. So the turn teams can be a variation of 1 to 2, or 2 nurses can be either 2 registered nurses or a registered nurse and a nursing assistant. A turn team program helps to ensure that routine care is being implemented for patients in the trauma ICU. And as I said, 2-person team consisting of registered nurses, and nursing assistant will turn ventilated patients every 2 hours. With effective communication between the patient's primary nurse and the turn team program, also TTP, which might be easier during the course of this to say that. So with effective communication between the primary nurse and the TTP, the patient's turning needs may adequately be handled, with less opportunities being missed for routine care. Not many resources are needed in order to implement a TTP on the trauma ICU unit, with communication being a key part of this intervention. A regular set of TTP assignments are posted at the beginning of each shift, so staff knows who has a responsibility for that shift. Furthermore, clocks are held outside of the rooms in order to determine when the next turn takes place. In case of a team being too busy or unable to perform the turn, effective communication plays a huge role in making sure that the task is performed. So again, this is just some more information that was kind of researched through literature in regards to the turn team program. For the QI model, I used Cotter's change model. A great change model that can be used for quality improvement is Cotter's change model. This model is known for creating and managing change. This is straightforward as it implements 8 steps in creating a change. These steps are the following: create a sense of urgency, build a guiding coalition, form a strategic vision for change, communicate the vision, remove obstacles, create short-term wins, consolidate improvements, and anchor changes. Pressure injuries can sometimes be overlooked as an injury that is unavoidable in the hospital setting. This could not be further from the truth, as they are very dangerous to the health of any patient involved. Furthermore, they can become extremely costly, as insurance companies are not willing to pay for treatment that is related to HAPIs. This can conclude that while happies are physically dangerous to an individual, they can also become a financial issue to both patients and hospitals, which we discussed earlier. Just kind of continuing with those 8 steps. As far as communicating the vision, this simple implementation of the changes that need to occur in order to help prevent pressure injuries from developing. Management on the unit and administration in the hospital should be aware of changes in order to see if they are adequately creating the change. However, to go even further into helping this change is to openly communicate with patients and families on the reasoning behind specific interventions. In this case, it's the turning. Patients should be aware as to why things are happening. As far as removing obstacles, this step is as simple as making sure patients' bed linens are frequently changed, eliminating excess wrinkles, and the possibility of any foreign objects in the bed that could contribute to creating pressure injuries. Making the job easier creates less strain on the parties involved, makes the turning easier as well. Creating short-term wins, the tools that should be set into place to document how many happies are occurring on a biannual rate. Knowing that these interventions are making a difference is a great moral boost for staff and patients. It also shows how well these TTP protocols are working on the unit. Anchoring these changes. This step is where everything is brought together. Every change has been implemented, assessed, and documented. What is left is the reduction of incidents as well as costs that are needed to treat further injuries. So methodology. This was done at the trauma ICU at Bergen Mercy, the TICU. This unit was surveyed on happy prevention. Bergen is one of only 2 level 1 trauma centers in the state of Nebraska, meaning that they receive the sickest patients needing the most attention to care. This unit specifically takes great pride in the prevention of happies, as the population consists of older patients who have suffered anywhere from ground level falls to severe motor vehicle accidents. The patients that were specifically surveyed for this project were those who were 50 years or older and those who were on the ventilator. The reasoning behind this is that those patients relied heavily upon interventions by staff in order to prevent the development of pressure injuries. We talked about the Braden scale earlier. This is used regularly on the unit, helps predict a score for those more susceptible to pressure sores. For patients at risk, so anything less than 18, certain interventions are used to help reduce and prevent happies. These are the following in addition to the turns. Specialized bed surface that helps to distribute the patient's weight, wound care consults for pressure prevention interventions, dietary consults for optimal nutrition, early range of motion exercises with the patients, moisture management, and then the proper use of moisture management with the proper use of catheters, creams, chuck pads, friction shear management with blue turn sheets. Patients and patients' families are also educated on the importance of happy prevention, and staff is regularly kept informed on new and existing policies through continuing education and quarterly skills days. When a pressure injury is found, an iris is placed which essentially is a complaint that can be tracked in order to make sure that the issue is being worked upon and resolved. Management keeps track of all the happies on a spreadsheet, and for any happies that is stage 2 or above, they are sent to nursing leaders of the unit, and a happy drill down is what it is called, is a form is completed in order to determine the root cause and opportunities for improvement. This form consists of the patient's name, when their first skin assessment took place, their initial Braden score, whether or not it was in relation to a medical device, the unit it took place on, when the injury was documented in the chart, the interventions that were applied, the location, all photographs of the injury, and the appropriate staging of the injury. Nursing leaders on each unit get a copy of the iris and happy drill down. They can then choose how to disseminate learnings, which can be through staff meetings, daily management boards, and emails. This helps staff to be made fully aware of what has happened and how to handle it and how to avoid it for future patients. So the implementation plan for the PICO question, again, it's the TTP, a two-person team. This will consist of either a registered nurse and a nursing assistant, or two registered nurses. So there needs to be at least one registered nurse in this team. Just because we are dealing with ventilated patients, there should be someone who's adequately able to handle that, as opposed to two nursing assistants or two CNAs. TTP assignments will change as appropriate for the unit. For instance, if a nurse has a lighter workload, then they will be assigned to a TTP. If there are any abnormal amount of vented patients, multiple teams may be necessary to ensure that turns are being performed. Within an effective unit, communication is key. If primary nurses are able to do their own turns, that can relieve stress from the TTP. However, it must be adequately communicated. Okay. So as far as tracking, what we wanted to do is basically a 6-month tracking period prior to the implementation of the TTP and then 6 months after it. Watching the staging criteria for HAPIs for previous 6 months without TTP as opposed to the next 6 months. And then we want to see if there's a reduction for potential of deep tissue injuries in patients. During this time, weekly skin checks remain constant on the unit, tracking any changes that are new or worsened for ventilated patients. This does not remove the responsibility for the primary nurse to perform their skin checks every shift, which should be done, just as normal. A Braden scale will also be documented every shift as well. The idea for using this assessment tool is that it may help show the progress of each patient. The score will ultimately be an indication if the patient regresses or progresses during their stay. The scale is charted for each shift so it can be adequately tracked. Overall, this is a great and easy way to assess and measure the progression of HAPIs for nursing staff, management, ancillary services, and providers. The key is to be able to adequately take care of patients by continuing routine care more efficiently. Communication is key to maintaining that turns are being done regularly. So this plan helps to provide a solution to this very common issue, despite having understaffed units, which is pretty common nowadays. It's not that it should still be considered a concern because it really is. However, just these routine things that we should be doing can be handled more effectively due to this TTP. The key is to be able to adequately take care of patients by continuing routine care more efficiently. And then by doing this, we're able to task med administration and just regular care in general. The other effective interventions talked about earlier too, just to help avoid HAPIs. It's kind of a domino effect in a way. Terms can be one of the easiest ways to help prevent this issue. So by doing that, it helps to free up nurses to do their other their job essentially. For an evaluation plan, the big one is documentation. This is kind of the key to nursing. This shows whether or not patients are progressing or regressing. It is a group effort to make sure that HAPIs are being continuously assessed, treated, photographed, and tracked as needed throughout a patient's stay in the hospital. Without proper documentation, there's no actual way to know if TTP is an effective tool in the process of HAPI prevention. Documentation is the only way to compare before and after the implementation of TTP. Continuing a proper plan using TTP can maintain a change on the unit and make the hospital stay much easier for the patient as well as the staff, the hospital overall. This can be, it's really its own separate charting. It can be either like an additional tab, depending on the charting system that's being used, or it can just be good old-fashioned paper charting. As long as it's being documented that these turns are being taken place. For dissemination strategy, just brief review, dissemination can be defined as the distribution of information and interventions to a specific public health or clinical practice audience. By the use of dissemination, research can be brought to the appropriate clinical practice audience who may be able to use that information for the greater good. These groups can use research and maximize its benefit without delay. In order to disseminate information, several types of approaches may be made. Typically, researchers may disseminate their publication in a journal, a public forum, or by a conference presentation. It really just depends on the type of information that is being broadcasted and who the researcher is trying to relay the information to. So what type of audience are we trying to reach? So for this particular project, really, I think hospital conferences are kind of the key, or the target audience, rather. The usage of a turn team or the most appropriate form of disseminations in regards to the use of a term team would be through hospital conferences with the possibility of an oral presentation. This type of research is specifically designed to better the lives of current patients and hospital care providers who are treating these patients. Ultimately, this type of information could be given at the source in order to properly expand on the problem at hand. The source itself being the hospital. So if we're able to relay this information in the hospital, it can potentially be acted upon at a quicker pace. This type of dissemination decreases the disconnect by allowing researchers to relay their research evidence and have practitioners and policymakers receive it accordingly. So again, this is just giving the right evidence to the right people. And oral communication is ideal, especially in this situation, being able to talk about the problem at hand and a potential solution. So with the conclusion, HAPPY's common problem in the hospital, but preventable. The idea behind a turn team program is to reduce the stress of the primary nurse by providing the regular care routines for patients. These turn teams help to deliver a simple yet effective solution for providing regular turns to intubated patients who are at a higher risk for hospital-acquired pressure injuries. HAPPYs are more evident than ever for older patients and those that are intubated and unable to turn themselves. With effective communication, teamwork, and a dedication to patient safety, a turn team program will help to reduce and potentially prevent HAPPYs within the hospital setting. And then here's my references.
Nice job. You can stop recording.